For the background, congenital pseudarthrosis of the tibia or CPT refers to non-union of a tibial fracture that may develop spontaneously or after minor trauma. It's a rare condition with limited epidemiological data, and its incidence varies between 1 to 140,000 and 1 to 250,000. The etiology of CPT is still unclear, and evidence shows association between CPT and neurofibromatosis type 1 or NF1, because it remains challenging in orthopedics, so it needs to be discussed deeper. This is our objectives.
So before we get deeper about congenital pseudoarthritis of tibia, let's talk about tibia. Tibia is a long bone that has weight-bearing function. In proximal, tibia articulate with femur and patella, forming a knee joint, and in distal, tibia articulate with fibula and talus, forming an ankle joint. Tibia in pediatric grow and develop through endochondral ossification of long bone.
Congenital pseudarthrosis of tibia is a rare case of deformity of the tibia that relates constricted tibia and fibula to atrophy and causing fracture or even pseudarthrosis.
The exact etiology of congenital pseudarthrosis of the tibia remains unknown. Aside from its name being congenital, pseudarthrosis doesn't always occur at birth or being pre-diagnosed. CPT manifests as a dysplastic anterolateral bowing of the tibia, cysts, and also tubulation failure that can lead to fracture. Despite the uncertainty, there are a few speculations about CPT etiology. First, it is speculated that this condition occurs from diseased periosteum of the tibia. The thickening of this layer then leads to hamartoma formation. The second speculation is the association of neurofibromatosis, which leads to hypoxia of the superior steel bone. Both conditions causing the bone prone to fracture. As for the pathophysiology, the disease progression begins from either diseased periosteum or neurofibromatosis. They then lead to anterolateral bowing of the tibia and migration of the fibula proximally, which increase the risk of fracture. When it doesn't heal, all deformities causing atrophy and also decreasing the size of calf muscles. This causes lack of loading in the tibia and also distal epiphyseal plates of both tibia and fibula, which are still growing. This then leads to the formation of fake articulation, or we know as pseudarthrosis, and eventually causing leg length discrepancy.
Classification of congenital pseudoarthrosis of tibia. Crawford classification is the most common classification of CPT. This classification is divided in 4 types. Type 1, the cortical thickening at deformities apex can be found. The medullary canal is preserved and some case does not show a fracture. Patients with type 1 indicate a good prognosis. Type 2, in this type, the cortical is thickened, the medullary canal is starting to thin out, and there is a trabeculation defect. Type 3, there is a cystic lesion. A cystic lesion is indication of a fracture. Patients with this type easily get a fractured bone, so they need an early treatment. Type 4 is present with pseudoarthrosis of tibia and fibular non-union.
The next is clinical manifestation. CPT has a special characteristic such as anterolateral bowing and variable shortening of tibia. The other symptoms are dysplastic, cystic, prefractures, and tubulation failure, and caveolate spot neurofibromatosis. CPT commonly occurs in first 4 to 5 years of life. The diagnosis of CPT using anatomical pathology examination and imaging examination, where the histopathology findings are abnormal thick posteo and the imaging finding based in CPT classification.
Basically, there are some various current treatment and management, and one of them is Williams intramedullary rod. This is one of the congenital pseudoarthrosis of tibia treatment with transankle fixation intended to restoring one of the bone function as the weight barrier both in static and dynamic condition. In general, the intramedullary rod method are divided into 3 types, namely as type A treatment as a section procedure of tibia fibular pseudoarthrosis and fibular shortening osteotomy that allows for contact and movement of the area around the section. Type B treatment has a similar shape to type A treatment without fixation of intramedullary fibula. Type C treatment is a form of fixation and bone grafting of tibia without treating the fibula. The William intramedullary rod has a fairly good level as initial surgical treatment for patient despite for its potential complication. Then when this treatment compared based on its type, the type A intramedullary treatment has a higher effectiveness of value.
The second treatment of congenital pseudarthrosis of tibia is Elizarov technique. The most effective treatment for congenital pseudarthrosis of tibia is surgery. Elizarov technique has been chosen as one of surgery treatment for CPT with 66% of healing rate. Elizarov is an external fixation technique which components are ring and connecting rods. For deformity correction, add hinges on the connecting rods. All these components should be adapted to the patient to maintain the stability of the fixation. In conclusion, Elizarov technique has been proven in repairing lower limb deformities and leg length discrepancy.
Okay, I will continue the current treatment and management of CPT, that is vascularized fibula graft. One of the difficulties in treating CPT is decreased blood supply to the distal tibia fragment post-fracture even after surgical intervention. So this can contribute to poor and non-union healing. So the solution to this problem is giving new blood supply with the vascularized fibula graft procedure.
Next is about prognosis and outcome of congenital pseudarthrosis of the tibia. It is very hard to achieve bone union in this particular problem, which result in unpredictable outcome. Certain problems may arise during and after treatment. Those problems are refracture after bone union, shortening of the limb, valgus ankle, and progressive anterior angulation of the tibia. Certain conditions may indicate worse outcome. Those conditions are both tibia and fibula are involved. The location of pseudarthrosis is in the distal part of the tibia, and in the patient with neurofibromatosis associated congenital pseudarthrosis of the tibia.
There is one new treatment being offered, namely mesenchymal stem cell therapy or MSC. MSC offers a complementary approach to improve conventional surgical treatment. However, the MSC quality of this CPT patient has not been studied further, although this therapy shows a promising strategy for bone healing in CPT patient. In bone tissue engineering and bone regeneration, mesenchymal stromal cells are currently the most mature cells. MSC in bone marrow can differentiate into different connective tissue like bone, fat, cartilage, and muscle. MSC have become an adjunct to orthopedic surgeons for bone graft as they can be obtained from the iliac bone marrow of each patient.
MCS could be isolated from fibrous hamartoma tissue or from trabecular bone marrow. MCS isolated from fibrous hamartoma tissue were performed in CPT patients associated with caveolite spots with a number greater than 5 and histologic fibrous hamartoma consistent with CPT. Meanwhile, the isolation of MCS from the trabecular bone marrow was performed in patients who underwent correction of the deformity or bone grafting by collecting tissue in a 50 millicentrifuge tube containing alpha MEM mediators. After MCS were isolated, MCS were characterized using cluster of differentiation or CD markers with flow cytometry. After isolating and characterizing MCS, the cellular senescence test was then carried out with the senescent cell histochemical staining kit from Stigma Aldrich. And after that, confirm the plasticity of MCS by means of chondrogenic, osteogenic, and adipogenic differentiation tests. Cells were cultured in complete medium to induce spontaneous chondrogenic differentiation, whereas osteogenic and adipogenic potential were evaluated by culturing cells in stumps pro-osteogenesis and adipocyte differentiation kits. All cultures were incubated at 37 degrees Celsius under normoxic conditions and analyzed after 7, 14, and 21 days.
One of the examples of the cases is an 8-year-old boy who came to the orthopedic department with history of significant shortening of left leg since birth and inability to use left leg for walking. General examination shows that he is a healthy boy with no sign of pallor, estrus, or clubbing. Although there are cafe outlet spots on his back and the local examination shows there is one discontinuity on his left leg while his right leg is completely normal. Also, his systemic examination is within normal limit. His X-ray of left leg shows bone discontinuity of both tibia and fibula, tapering ends of tibia and fibula, and callus formation at the site of the deformity.
So the summary of our STEM project or congenital pseudarthrosis of tibia is a rare case of tibia deformity that causes tibia and fibula atrophy, fracture, or even pseudarthrosis. The clinical symptom of congenital pseudarthrosis of tibia such as anterolateral bone dysplastic abnormality, fibula, and pseudarthrosis. The cause of CPT is still unknown, but there are some speculations about CPT will occur. Congenital pseudarthrosis of tibia can be caused by three bone conditions such as anterolateral bowing fracture that does not heal well and migration of fibula proximally. The prognosis of CPT depending on the characteristic of each case. There are some treatments that common use like William intramedullary rod, Elizarov technique, and vascular fibula graft. There is a new treatment method, namely mesenchymal stem cell therapy or MSC. However, although this therapy show a promising strategy for bone healing in CPT patients, the quality of MSC in this patient has not been further studied.